Thank you everyone for attending this evening. It's really appreciated that you can make the time. My name is Ralph Brown. I'm the network manager of the West London HCC, and this evening I'm joined by Professor Eduardo Olivarria, who is the program director for the bone marrow transplant unit at Hammersmith Hospital, and Dr. Stephen Okoli, who is one of the clinical hematologists involved in the care of people with hemoglobinopathy, so sickle cell thalassemia. And they are going to give a presentation and an update on bone marrow transplant as a treatment. So in terms of the order of the session, Eduardo and Stephen are going to give an initial presentation, which will be recorded as some patients have been unable to make the session, and we will upload that to our YouTube channel at a later date. And then after that, if people have questions, they can then put up their hand or use their microphones for a question and answer session thereafter. If you think of questions during the presentation and would like to jot them down, there is a chat function in Teams, so you can put them in and I'll make sure to ask Eduardo and Stephen the questions at the end. If everyone could try and keep their mics on mute, that would be really appreciated during the presentation, just so that we don't have too much background noise. Okay, so thank you everyone for attending this evening, and I'll let Eduardo and Stephen get going.
So, hi everyone. I was just going to start with a short presentation of our current sort of landscape regarding treatment for sickle cell disease, which, as you all know, is fairly limited, and then move on to Eduardo to do the more exciting parts of the talk, to talk about what options which are available now, and hopefully some of you will sort of take up over the coming months. So it's a very short presentation because I see the main focus is going to be on the discussion about, or your questions more than me and Eduardo talking. So I will just load my presentation now, and then we can get on with this. As Ralph said, I'm Stephen Okoli. I'm one of the sickle consultants here at the Hammersmith. It's my pleasure to sort of talk to you today. And what I wanted to start off with is basically just trying to give some insight into the impact of sickle cell disease on all of you, all the patients with the disorder. Sickle cell disease affects every organ affected with a blood supply and causes a whole myriad of symptoms and complications. Unfortunately, some of which are life-limiting, though a significant of the symptoms that patients do impact on their quality of life. So offering patients viable treatments, cures, is an essential part of looking after patients with sickle cell disease. So this illustration is one that I got from one of my colleagues, and basically what it tries to chronicle is the options, the treatments and the interventions that have been made available to patients with sickle cell disease. Things like newborn registries, trying to establish treatment for sickle cell disease in law, which has been done, and also the pivotal studies that have changed the way in which we treat sickle cell patients. However, despite these relatively minor interventions, it has had some significant impact on disease, but there's still a lot to do. One of my colleagues did a registry study of patients with sickle cell disease in 2016 and indicated that the average lifespan for that cohort was about 67 years. And that's a significant improvement on previous reviews. However, that does mean that sickle cell patients, their life shortened by about 20 years compared to their ethnically matched peers, which to my mind is still not good enough. So where are we at the moment? What treatments do we have available for sickle cell patients? Hydroxycarbamide is a well-established treatment for sickle cell disease. There's good evidence that it reduces the admission rate, the frequency of painful crises, and some of the more significant complications of sickle cell disease, particularly stroke and acute chest syndrome, the major causes of sickle morbidity, death, unfortunately. And however, the response is variable. It's associated with a significant number of complications. And the main reason for this is because sickle cell disease, this drug was not designed for sickle cell disease patients. It was designed predominantly for other indications, and has been what we call repurposed for sickle cell disease. It's very effective at what it does, but because of its nature, it does come with a significant amount of side effects. And because of the fact that it wasn't initially designed for sickle cell patients, it does come with some misconceptions. This illustration is purely to show that the drug works on multiple levels in sickle cell disease. And by modifying them in multiple sites, that's why it's so effective in treating the disorder. And I've put this in purely just to show, as a hematologist, I love showing blood films, the illustrations of the blood cells under the microscope. And as you can see on the far left, that the sickle cells, this long, thin cell that's spiked at both ends, the classic sickle cell. And this is a patient who started on hydroxycarbamide, initially had a relatively low hemoglobin, but after 2 months, then again after 3 months, the hemoglobin has continues to rise. Along with that, the fetal hemoglobin, a marker of response to this drug hydroxycarbamide, was also increased, and the cells got bigger, able to take on more hemoglobin and better hydrated, so more resistant to the stresses that sickle cell can cause. But as I alluded to earlier, there are side effects. Though in the vast majority of patients, it's fairly well tolerated. There's some theoretical risk of fertility, but this is reversible. Some patients do get some gut-related problems, and there is a risk of transient change in blood counts. Now, there was a suggestion, and a previous suggestion, that may be associated with cancers. This has been refuted, but this is a drug that does have problems. The other option for sickle cell patients are transfusions, and these can be delivered in one of two ways: a simple or top-up transfusion where you have a cannula inserted and get the blood that way, or a slightly more complicated but more effective exchange blood transfusion, where the sickle cells are removed and replaced with fresh, non-sickle donated blood. But as with everything, it does come with its problems, and because the blood is not ethnically matched, so the vast majority of donors in the UK are of Caucasian heritage, while the donors or the recipients, the sickle cell patients, are predominantly of African and Caribbean descent. So we know that increases the risk of developing antibodies, and that makes patients, that has this immediate risk associated with transfusion reactions, but also makes further transfusions more complicated. Iron overload, because red cells are rich in iron, that is another risk that does have to be managed. And there's always a risk of infection. In the UK, we have excellent screening systems to reduce that risk, but that risk, unfortunately, is not zero. So this is a slide that shows all the treatments that have been used over the last 10 years in sickle cell disease. What is remarkable is that other than the two that are highlighted here, none of them were designed specifically for the treatment of sickle cell disease. They're all drugs that have been, as I said, repurposed. So they were designed for another reason, but the drug companies felt that it may be beneficial for sickle cell patients. So as a result, they were trialed. Unfortunately, none of them were all that effective. The two that have been shown, and we'll talk about this briefly in a second, to have some effect were crizanlizumab, which has been available via managed assets program, and voxelotor, which we're struggling to get access to via NICE at the moment. The story unfortunately doesn't end there because crizanlizumab, unfortunately, the most recent studies suggested it's no more effective than a placebo, than a treatment that doesn't have any therapeutic effect. So it has been withdrawn by the EMA, the European Medicines Association, that's sanctioned drugs in Europe. But as we've left Europe, the decision is been delegated from our perspective in the UK to the UK regulator, which is still pending. So the patients who are already on crizanlizumab remain on it, but as a sickle cell group of sickle cell doctors, we feel that's likely going to change in the coming months. And as I alluded to earlier, voxelotor, unfortunately, is not an option available to us. It's going to NICE for the third time. It's gone to NICE for the third time, waiting for a decision, but at the moment isn't an option available to us by the NHS. So now we move on to newer options. And I have this slide about the no one's listening, the all-party parliamentary group report from two years ago now. And one of the things that was highlighted, that there was very little money being invested for research and treatment in sickle cell disease. And you all know that this is the fact. However, over the last couple of years, we have had increasing interest in trying to develop treatments, and hopefully things like stem cell transplantation will be options that will benefit a lot of our patients. So I'll hand over to Eduardo now for him to finish off the story.
Thank you, Stephen. I'd rather start the story rather than finish the story. I think it's a better way of describing. And you have to bear with me because I don't know very well how to share my slides. Here we go. I think I can see them on my screen. Can you all see what I got there?
Yeah.
Okay, so I'm going to talk about one of my favorite topics. So possibly we'll spend all night on this because I can talk for hours and hours, hopefully not that long. Bone marrow transplant, BMT, blood and marrow transplantation, BMT, stem cell transplantation, they're all the same thing. Different names, old name is BMT, new name is stem cell transplant, but it's basically the same thing. So, what's transplant? The beginning, as many advances in medicine, it comes from human stupidity. So human beings are wonderful, most of them, but as a species, we're really, really harmful to each other and to the planet. So some clever guy many years ago invented the atomic bomb. Not only that, we dropped a couple of them in Japan. And after that, we discovered that that's never a good idea, and that radiation from the bomb killed a lot more patients because of cancers and toxicity than the actual bomb. So we kind of try and learn the lessons. And one of the lessons was that radiation, if given it low amounts, say 1 gray, it doesn't cause any damage. Can go all the way to 12 gray and only damage the bone marrow or the production of blood cells. If you go over 12 gray, you start damaging your gut, your brain, and eventually you will die of that. In fact, those who get exposed to big dose of radiation almost always died of a gut toxicity way before the bone marrow failure kills them. So at the same time, we discovered that you can irradiate lethally mice, but if you protect the bone marrow or the spleen, then the bone marrow function is protected and they don't die of a lack of blood. And that was the way we discovered the concept of the hemopoietic blood stem cell. So we have in our bodies one cell, many of those, who are really stem cells, and they can multiply and divide and produce all sorts of cells in the blood. You can see them here. They produce the immune system cells called lymphocytes, the platelets, the white cells are defenses against infections, and they also produce the red cells, all of them in the bone marrow. So the idea is that if you got a stem cell that, because you're born with a particular genetic mutation and produces abnormal red cells, for instance, then you can take away those stem cells and put new stem cells without the genetic defect, and therefore the red cells will be normal. However, not only the red cells will change, everything else will change. The white cells, the lymphocytes, the immune system, the platelets, the whole of the blood and the immune system will necessarily change at the same time. So that's basically a transplant. So there's a lot of debate about who did the first transplant. The official answer is some clever doctor in Seattle in the United States. However, in 1958, another human stupidity, a nuclear power plant in Yugoslavia went off and killed a lot of workers, and 6 of them were survivors, and 5 of those 6 were treated in Paris by George Matte with infusion of bone marrow from family members. George Matte didn't call this a transplant, but it was a transplant, and I have to say that all 5 survived after the exposure to lethal radiation in Yugoslavia. So to me, that was the first transplant. However, the official transplant was somewhere down in America. There's 2 types of transplant. Basically, we can do what we call an autologous transplant, which means that we will do the transplant using the patient's cells, or we can do a transplant using someone else's cells. Autologous transplant, we got the patient that for the first few days becomes the donor. So we give something called the growth factor, and that means that there's plenty of stem cells in the blood circulation. We can collect them using one of those cell separators like a dialysis machine, and we can freeze those cells for future use. Then the patient becomes the recipient, and we can give the patient chemotherapy or radiotherapy to try and kill the cancer, the leukemia, the lymphoma, or the bone marrow. And once we've done that, we can thaw and reinfuse the cells. I just want to say at this stage, although it's not for this talk, maybe for next one, Ralph, that once we collect the cells and before we freeze them, we can now have the ability to genetically manipulate those cells and theoretically correct the genes that have been mutated at birth. So when you can thaw and reinfuse the cells, you can infuse cells that have been altered to become normal, and they no longer have the genetic defect, for instance, the sickle cell genes. But that, as I said, will be for a different talk. Now, the second type of transplant is what we call allogeneic transplant. That is taking the cells from another person, which is compatible, a compatible donor. We give the chemotherapy and radiotherapy to the patient, and then the cells, instead of being collected in advance and frozen, they come directly from a compatible donor. So the transplant is a process. It takes months. We infuse stem cells obtained from a compatible donor after conditioning the patient with chemotherapy or radiotherapy. It takes, as I said, months. It starts even before the transplant when we're trying to find a compatible donor. We talked about this in a second. Then the chemo radiotherapy of the conditioning, anything between 3, 5, 14 days sometimes. The day that we infuse the cells, we call this day 0. And thereafter, we count the days in positive. Engraftment means that the cells that we put in are now able to produce blood cells, which are now different from the blood cells the patient has had since for entire life. These cells are now different because they are the donor cells. They're exactly the same as the cells the donor had in their blood. But the immune system recovery takes a lot longer. So for 6 or 12 months, these patients now have to live with an immune system that is pretty much a weak immune system. You can look at it as if it was like a baby, a newborn baby immune system. You wouldn't look at a baby like a strong immune system until it develops a bit more. Same thing with after transplant. These are the guys in Seattle that published in the 70s, the transplants done in the 60s. You can see they were all following the fashion of the year, nothing to do with what we would dress up in nowadays. And this is a picture of a nice city, Seattle. And these are the number of transplants that we've been doing in Europe over the decades. As you can see, started in the 80s, 90s. Not many, but again, both autologous in red and allogeneic in blue are going up. And there's a little blip at the end, and this is just the COVID pandemic. The number of transplants in the last 2-3 years have decreased or didn't increase as much, simply because of the risk of COVID infections in some of our patients. And these are for everything, leukemia, lymphoma, all sorts of cancers as well. The European Blood and Marrow Transplant Society involves nearly 700 teams across Europe and other places in the world, 52 countries, and in 2021, even during COVID, we did almost 50,000 transplants. We have a registry of over 1 million transplants done since the 1970s. So what a lot of transplant patients out there that we can tell you about. Now, these are the rates in Europe. The darker you go, your country, the more transplants you do per inhabitant. As you can see in the UK, we're dark green, but not necessarily as darker as Germany or Italy. So we could do more, and we could do better, I think, in the UK. So how do we collect the cells? I've said that we can collect those cells using a machine, but that's not the only way. We can collect the cells from 3 different parts of the body. One is directly from the bone marrow. The second one is fish them out from the peripheral blood, from the circulation after the GCSF growth factor. Or we can collect them, we got just one opportunity, from the umbilical cord when you're born. When a baby's born, the placenta has a lot of stem cells. In fact, 1% of the cells in the placenta are stem cells, 1% of the cells in the bone marrow are stem cells, only 0.1% of the cells in the blood are stem cells, and that's the reason we need to collect a lot more blood than marrow. Now, the cord blood, we're limited. We can collect only what is in there, so not a lot. In fact, only 100 mils of blood will be the average collection from a placenta when a baby's born. I hope you don't mind me putting a picture here. This is just a surgeon collecting cells from someone's bum directly into the bone marrow. This is a donor donating cells using the cell separate machine. I have to upgrade this slide because it's a very old version of the machine that we have there. And this is the complications of trying to put a needle through the umbilical cord of the placenta, trying to collect as many cells as we can on the day. At the beginning, we only had bone marrow. We didn't know that we can collect them from the blood. But once we reached the late 90s, beginning of the 2000s, then we realized that that was possible, and it's a lot easier, and we collect a lot more cells using the blood. And as you can see, the blue bone marrow came down, and we only do a few bone marrow transplants as such in current years. The green is the peripheral blood expansion. The vast majority of transplants are done from cells collected from the blood. And the last 5-10 years, we've been focusing a bit more on collecting cells from the cord blood and use them for transplantation. I mentioned the conditioning. I said that the patient needs to have chemotherapy, sometimes radiotherapy, to try and kill the disease. And we can give a lot of conditioning, or we can give a small dose of conditioning. RIC stands for reduced intensity conditioning, and it minimizes the toxicity, it minimizes the transplant-related mortality, so you go down on the amount of chemotherapy and the patient has an easier ride. However, if you don't give a lot of conditioning, you may have the leukemia returning later, or the transplant may fail. To try and avoid that, you can increase the amount of chemotherapy, and then you kill the leukemia, and you guarantee that the transplant goes in. But if you give too much chemotherapy, then you have a very high transplant-related mortality, obviously, and that is a problem, especially when you're dealing with patients who might be a little bit old, as we have been doing in the last few years. Now, we've been progressing a lot in reducing mortality. If you were to have a transplant in the 80s, your doctor will be telling you that there is about 30% or maybe 40% chance that you don't survive your transplant. And in those years, we only offered transplant to very young people under the age of 40 or 45. And despite this, the transplant mortality was very high, as you can see there. But every decade or every 5 years, you analyze this is like 17,000 patients or so in the European registry. You can see that nowadays the mortality should be around 10% or even lower sometimes. So we're getting better. The mortality is due to a number of complications after transplant. I mentioned that the graft could fail. So if we don't do enough, we just transfuse the cells from the donor, but the cells never pick up and never produce new blood. I mentioned, although less relevant to this audience, that the leukemia or the lymphoma or the cancer could return despite the transplant, and that is obviously a big failure for the transplant. But I guess for today, the two main complications of the transplant are infections, and these are due to the period of time where the patient has to change the blood for the new one, and during that time there is no defenses in your blood, no white cells, and also for the 6 or 12 months that it takes for the immune system to get stronger, mature, and effective in fighting viral infections and other things. So the risk of infections is great at the beginning, it goes down slowly over time, but nevertheless there's a number of months where infections could occur. And the last complication is the reverse of the graft failure. That is that the cells that we put in could potentially attack the patient from the inside out, is what we call the graft versus host disease. And it only happens when you use the cells from another donor, not for when you use the cells from your own marrow. So what is GVHD? What is graft versus host disease? That's an immune attack when the donor cells recognize the patient as different. This is not my body. This is not the person I was living in, and someone's taking me away from my body and put me into a different body, a different patient. And it could be early on, acute, that affects the skin or the gut or the liver. It could be chronic, that could last for many, many months or even years after the transplant. I'm going to skip this because it's just a picture that describes how we cause GVHD. We give a lot of chemotherapy that causes damages in the skin and the gut, and then there's an interaction between the patient cells and the donor cells that produces a lot of inflammation, and those cells will be now directed against the patient's gut or the patient's skin to produce damage. If it happens at the beginning, we call it acute, and it's a bit of an explosion. If it happens after the first 3 or 6 months, then we call it chronic, and it's normally a very slow progression of symptoms, and it could take several years before it goes away. This is a picture of the skin, how it looks like. It looks like a tourist in Mallorca without any sun cream, and it can get really, really bad with blistering and really very uncomfortable for the patient. The chronic GVHD, it could involve any organ for many, many years, and it's a complication that we very much like to avoid. But I would like to mention that it could affect the skin, the mouth, the liver, the eye, your gut. Your weight doesn't go up. In fact, it could go down quite dramatically. But in theory, it could affect any part of your body because your immune system now has turned against yourself. The donor's immune system has turned against yourself. There's some pictures that will probably glance over how the skin could get very dry, your nails don't grow, your mouth is full of ulcerations, and it could affect your quality of life a lot, of course. We know that the GVHD could be more frequent if we have a donor that is not fully compatible, if the patient is very old, if we give a lot of chemotherapy during the transplant, or if we found a female donor for a male patient. That is the wrong combination because female immune system cells will definitely attack male cells in the patient's gut or skin. We can treat it. We have a number of treatments that we can give to ameliorate, and in many cases the GVHD goes away and disappears completely, not always, or we can try and prevent. And we've got a number of medicines, and we can even manipulate the cells that we give in before we infuse them in the transplant. In fact, I can today guarantee a transplant without any GVHD. The chances of graft-versus-host disease is about 20–30% if we don't do anything for the transplant. But we have technologies today that would abrogate completely the risk of graft-versus-host disease. However, if you do that, 0 chance of graft-versus-host disease sounds very good. However, there's a price to pay because then maybe the transplant is not as effective, and then you will have more infections, or you will have a better chance or a higher chance of the leukemia returning. However, if you're not dealing with a malignancy, a cancer, then you're not too afraid about a cancer returning because there is no cancer in the first place when you did your transplant. So finally, I mentioned allogeneic transplants, but it depends on which one is the donor. We do the transplant in one way or the other. So very, very quickly, the best available donor today is what we call an identical sibling, a brother or sister who is HLA identical. It's the perfect match. And it has the usual complications that I mentioned before, but the main one, of course, is that some patients don't have many brothers and sisters. And if they do have any brothers and sisters, they may not be identical or compatible with the patient. So we are limited by the amount of siblings that each individual patient has. What is compatible? So we call it compatible or identical when someone has the same 12 genes. We look at 6 genes, and each one of the genes comes from one dad and the other one from mom, so it's 12 in total, and we call them compatibility genes. We call them HLA-A, B, C, DR, DQ, and DP. And this is standard family. So mom and dad at the top, and they all have a number of genes, and just for the example, I call them A1, B1, DR1, A2, B2, DR2, that's for mom, and A3, B3, DR3, A4, B4, DR4 for dad, and I just color-coded it as well, even if I'm colorblind and I cannot see the colors that well. So the patient in the middle has inherited from mom the blue ones, the blue genes, so the patient is A2, B2, DR2, and from dad, the red ones, so the patient is A3, B3, DR3. And sibling number 1 has, by chance, inherited the opposite genes from mom and dad. So the green instead of the blue, A1, B1, DR1, and the yellow instead of the red, A4, B4, DR4. So this sibling number 1 and the patient are completely different, no match whatsoever. Now, sibling number 2, by chance, has inherited exactly the same package of genes, and this sibling number 2 happens to be identical. So the chances of this sibling being identical is 25%, 1 in 4. The chances of this sibling being not a match is 25%, 1 in 4. But there's a third option, the third alternative. So it could be that the sibling has inherited the same one from mum. So it's the blue, and instead of 1 is now A2B2DR2. And in this example, the sibling has now inherited the yellow from that. So yellow instead of red, that's not compatible, but blue and blue, they're now compatible, but the compatibility is only half, only 50%. We would call this sibling haploidentical or 50% identical. And this haploidentical donors could also be used in a transplant. These are the chances for you, those of you who like mathematics, of finding a compatible identical sibling, depending on the number of brothers and sisters you have. So 25, 50% if you only got one, 50% or so, but increases. There's a point where mum and dad should stop having kids because it doesn't increase your chances of having a compatible donor anymore. Unrelated donors are those who are not family members. We can try and match them either completely or only partially according to those 12 genes. More donors available. We have about 45 million volunteer donors out there that we can try and find a good match for the different patients. The problem is that the chances of finding a donor depends on your ethnic background, and that is totally unfair. If you're white European, you've got a 95% chance of finding a donor in the registries because the vast majority of the donors in the registries are white European. And in fact, you can see in the blue column, more than 75% chance of finding a perfect match. However, if you're Middle Eastern, North African, African American, or of African ascent, then the chances of finding a donor go down to perhaps 70%. But look at this. The majority of donors we find are not fully matched, are incomplete matches, and only 20% or so are full match identical donors. So we have to make do with less than good donors for those populations. And the reason is we don't have enough donors from the different ethnic backgrounds. This is an American registry, but it mimics more or less what happens in Europe. Obviously, we don't have a lot of native Hawaiian in Europe, but apart from that, at least 50% of white donors, only 20% or so are from ethnically diverse backgrounds. And we really need to improve on that. So around 30% of our patients will have sibling, 30% might just find on time a match unrelated donor, and 40% are left with no donors. And that's where the haploidentical transplants come in. This is the same numbers in Europe, as I've shown you before, showing that the unrelated donor transplants have been increasing over time, that perhaps we've reached the maximum of sibling donors because we now cannot have any more siblings in our families, and that is the total amount of transplants in Europe that we can do using a sibling. However, and whatever color that is, orange perhaps, the number of haploidentical donors have increased in the last few years. And this is because the techniques for transplant have been perfected, and we can now use 50% match donors from the family as donors, which means that almost anyone has a donor. Now, to the point that this is American data, you can see that the haploidentical donors are now being used preferentially or more often than siblings. They have even a bigger problem with sibling in America. Haploidenticals are very good because they're not fully compatible. They're only 50% compatible, so they have a very good effect against the leukemia. But the vast advantage, the main advantage, is that nearly every patient has a donor. So 100% donor availability if we use a 50% match. And I'm going to leave it there because I believe that Steve has a bit of information about haploidentical transplantation for sickle cell.
Actually, Eduardo, I hadn't done any slides because I wanted to leave the rest of the time for a discussion, if that's okay.
Okay.
So, the redress study, I can just quickly talk to you about. So the redress study is a research study that's run out of King's College Hospital. We are one of the first second site in the UK to become active for this study. And as Eduardo sort of explained quite eloquently, is that unfortunately most patients with sickle cell disease don't have the current research suggests it's about between 15 and 80% of patients with sickle cell disease have a fully matched sibling donor. So though it's a fantastic option, it's unfortunately not an option for the vast majority of patients with sickle cell disease. The study gives the option of a haploidentical transplant, and again, as Eduardo said, the vast majority of people have a half-matched donor, and this study has been mandated by the NHS to be a one-to-one comparison. So the study will be randomized, so those patients who have a matched donor and are willing to proceed to the study will have a 50% chance getting a transplant and a 50% chance to continue on the treatment they have. Doesn't sound fair, however, it does give people an option, and it means that there's at least a chance that if you do have a potential donor, that you can receive a transplant from a position up until now where the vast majority of patients didn't have any option. So if that's something that patients want to consider, then we're very happy to have those discussions with them to go or proceed to tissue type family members, and then discuss the options and just decide where to go from there.